Ladies and gentlemen, thank you for standing by and welcome to the CRP Quarterly Board Educational Webinar. At this time, all lines are in a listen-only mode. Later, we'll conduct a question-and-answer session, and instructions will be given at that time. If you need assistance during the conference, press star followed by 0, and as a reminder, we are recording today. I would now like to turn the conference over to Michelle Cooper. Please go ahead.
Thank you. Welcome, everybody, to our educational webinar for governance titled Laboratory Compliance, Maintaining Compliance in an Uncertain and Changing Environment. And this is a governance perspective. I'm Michelle Cooper. I'm a CHI Systems Corporate Responsibility Officer, and we're excited to be offering this opportunity to you. I am going to turn it over to Susan Shiflett, who is the Vice President of Corporate Responsibility, and she will offer a reflection as well as introduce our speaker. Susan?
Thanks, Michelle. Yes, if we could all just center ourselves in the presence of our Lord. As we gather, Creator and Source of all being, we give you thanks for the beauty of this day, for the gift of this world, and for the gift of each other. We especially give you thanks for the gift of our vocation to Catholic healthcare. We thank you for the ways in which you become present to us in our service of the sick and the suffering, the poor and the outcast. As we gather here, we ask you to be with us as we continue to reflect on this unique vocation and seek to live it more fully in the world. Open our eyes that we may see what you wish us to see. Open our ears that in our dialogue we may hear what you want us to hear. And open our hearts that we may feel as you feel towards those in greatest need of our services. Bless all that we do here in our gathering. May it be a holy work done in your name. We ask this in your name. Amen. Well, thank you for joining today. And today we have Tim Murray, who is the Director of Laboratory Compliance for the compliance team at Catholic Health Initiatives. Tim joined CHI in actually 1990 when he joined one of the founding healthcare organizations, St. Joseph Medical Center in Reading, Pennsylvania. And he has a master's degree in administrative and clinical laboratory science, and he also has a professional certification as a medical technologist. Tim joined us in 2012 as the National Compliance Director for the lab, and he oversees all aspects of laboratory compliance activities for CHI. Tim also is a recognized leader in laboratory compliance, as he serves on several professional organizations. He's also very active in our advocacy work through CHI. He's connected to the American Hospital Association, and he's going to talk more about that later in his presentation, so I won't go into all the detail, but he has really helped CHI in laboratory efforts. And so with that, I'm going to turn it over to Tim.
Okay. Thank you, Susan, and I appreciate that nice introduction. And I just want to also wish all of you a good afternoon, and thank you all for attending today's CHI Laboratory Compliance Informational Session. As Susan mentioned, we're going to talk about laboratory compliance, maintaining compliance in an uncertain and changing environment, a governance perspective. And I can tell you from personal experience, laboratory regulations are changing by the day. As Susan said, I've been in this position about 6.5 years, and it is my pleasure to speak with you about this subject of laboratory compliance, which, as you will soon hear, is where my passions in compliance are focused. So let's take a look at slide number 2. Okay, so what do we want to accomplish today? We want to give you a high-level overview of our program so that each of you, the leaders of our company, can understand CHI Laboratory Compliance's initiative. I'll highlight laboratory compliance risk areas and CHI's response to mitigate those risks, and provide an overview of our laboratory advocacy efforts. Lastly, I'll identify key takeaways for you all and in the Board of Governance. So on slide number 3, Additionally, I'll be reviewing the strategies we use at CHI in developing our laboratory compliance plan, and through the implementation of this plan, reduce risks so that none of our laboratory leaders, local compliance professional, or any of you will have any professional involvement with the many regulatory agencies that oversee laboratory compliance. You know, honestly, our laboratories are loaded with compliance landmines, whether they're self-inflicted by the laboratory itself, or it's due to unclear rules and regulations, or the fast-paced atmosphere that our laboratorians live in. Clinical laboratories were the first healthcare entities to come under regulatory scrutiny by the Office of the Inspector General, and you know them as the OIG. And that goes back as far as 1992, when the OIG had embarked on a Project Lab scam, and it was to investigate fraudulent billing practices by clinical laboratories. There were millions of dollars of fines that were assessed to the large laboratories, which you'll easily recognize, the SmithKline Beecham, now Quest, and LabCorp. These investigations and findings led the OIG to develop the first laboratory model compliance plan. I don't know if that's such a good thing, but it happened nonetheless. These investigations have continued, and today we're still seeing settlements, and we're still seeing imprisonments and fines being levied for not following the rules and regulations. I can give you a couple quick examples. A laboratory miscoded its drug screen specimens and was looking to get a higher level of reimbursement. The laboratory management in that laboratory notified coding management, but no action was taken. This caused a whistleblower situation and, in the end, caused a huge settlement of $6.5 million in a false claim settlement. Another situation is where the laboratory didn't have the appropriate equipment ready to test specimens for which they already had received. So what did they do? They froze the specimens, kept them for 7 to 10 months, and after they got their equipment up and running, they tested them, billed the patient's insurance, and didn't mention the delay to anyone. This resulted in prison time and another large settlement of $15.7 million to the ordering provider who owned the laboratory. So these are all things that are happening monthly. We continually read about these types of settlements that the OIG publishes. These old and new issues are the ones that got us to this point in the life of our laboratory compliance program. In the Federal Register from 98, the OIG stated that laboratories need to move to a higher level of conduct. That is why it's so important that we heed and understand the OIG and making compliance part of the fabric of every laboratory's culture. We need to make these compliance plans something that does more than sits on a shelf. We need to take compliance programs seriously and also to help change the culture. So on slide number 4, I know you are aware of the purpose of the compliance program, but I'll be discussing how we at CHI accomplish these things. As I said, it needs to be in the culture. In later slides, we'll provide you with specific examples as to how we ensured we meet these laboratory compliance standards. The OIG laid out what these plans were to accomplish and their purpose in its published model compliance plan. Fundamentally, compliance efforts are designed to establish a culture within the clinical laboratory that promote prevention, detection, and resolution of instances where the conduct of the laboratory staff do not conform with federal, state, or private healthcare payer requirements, as well as the clinical laboratory's ethical and business policies. In practice, the compliance program should effectively articulate and demonstrate the organizational commitment to this process. The existence of benchmarks and demonstrate implementation and achievements are essential to any effective laboratory compliance program. So we need to do things like write policies and procedures, effectively train, educate people, respond promptly to detected offenses. Eventually, as the OIG expects, a compliance plan should become part of, again, the fabric of the clinical laboratory operation. And that's what we strive to do in CHI with our laboratories. This is, again, the only way a laboratory compliance plan works. There needs to be a commitment across the organization and not only at the top. So moving to the next slide. So here you will see a slide that has a timeline of things that occurred in CHI. And it's how CHI got into the laboratory compliance business. This was an incident where one of our newly acquired small physician office laboratories, and they, like I said, they did own and operate a laboratory, was reported to CMS for referring proficiency testing samples to another laboratory for analysis. This is a huge red flag. But to give you guys a little bit of a background on what proficiency testing samples are, proficiency testing is basically a government-run program to ensure that a certain level of testing quality is conducted at any one licensed laboratory. The government requires each licensed laboratory to participate. Each lab receives government-approved specimens to test for specific lab values. The testing labs have no idea what the right result is. They analyze the specimens and send the results back to the government for a pass-fail grading. Only labs performing successfully may continue testing and billing for these services. So that's the key. If you're not successful, you can no longer perform the test and provide diagnostic information, and you can no longer get paid for doing that test. So this is a very highly regulated program to avoid cheating. So back to the slide. In April of 2010, after we were reported for sending a proficiency testing sample out, CMS came in and conducted a complaint survey and investigated if we indeed did not follow the stringent regulations. In 2010 of April, we were notified of their findings by CMS. Accusations were upheld, and the laboratory was notified of the revocation of their laboratory license for 2 years. So that puts us out of the laboratory business. In addition, part of the regulation requires that the medical director, the doctor responsible for the testing, lost the ability to hold the position of lab medical director. 2011, operations ceased in that laboratory. In March of 2012, so this took a bit of time to go through, CHI agreed to a settlement with the government. And during the negotiations, just to give you an indication of how serious this all could be, CMS threatened to revoke all of CHI's CLIA laboratory licenses, which would have been catastrophic for CHI's ability to produce quality health care across the system. So as part of our settlement, that did not happen. But what we did settle upon is that all testing staff, and in our case it's 49,000 individuals, were required to participate in proficiency testing education. These individuals, all 49,000, including individuals, the nursing staff, who were performing those very simple tests that were called waived testing, as well as professional laboratorians who were performing the higher level complex tests. Even though, and it was interesting because we at CHI tried to say, well, the nursing staff who perform those simple tests shouldn't have to participate in this training because proficiency testing those unknown samples is not required for that level of testing. But nonetheless, we had to acquiesce, and all 49,000 members of CHI's testing staff had to be educated. Okay, so let's move along to the next slide. Okay, so how many CHI laboratories are we currently responsible for conducting a compliance program? This slide gives you the laboratories and their concentrations by division. You'll see the majority of our laboratories, if you look down at the last line, grand total, the majority of our laboratories, 77%, are physician office laboratories. So you see that we have 448 physician office laboratories. and most of them performed what we were just talking about, waived testing, the simple testing. You also notice that we have 109 hospital laboratories. We have 24 larger laboratories, which are outside of hospitals, and those generally perform testing for large group practices, so they're bigger than the individual physician office. And then, so that gives us a total of 581 laboratories across the enterprise, which is a lot of laboratories to worry about compliance with. Okay, so on the next slide, so how did we get started on this roadmap of implementing National Laboratory Compliance Program with all the laboratories we just reviewed, the complexity level of the regulations governing them, and the recent, at that point, government settlement? We, as CHI, decided to develop a National Laboratory Compliance Committee that would help determine the course of laboratory compliance throughout CHI. We needed to organize our specific compliance efforts, and what you'll see on the next two slides was the charge this committee was given. So you'll see, we were given the charge of developing a compliance plan, monitoring tools, formalizing and training of new and existing materials, and on the next slide you'll see that we needed to on the next slide you'll see that we also needed to review national issues. We had to review the existing compliance plan annually. So there was a lot to do. We had a lot of charge that we had to make sure we could reach. So, but it was decided with this newly formed National Laboratory Compliance Committee that we wanted it to be made up of representatives from each of our markets. So we went out and invited people to join our committee. And as we reviewed this charge, we decided that our first objective was to, A, develop a overarching laboratory compliance plan for our labs. And it took us about a year to pull the plan together. On the next slide, if you'll move to that, we decided that our compliance plan would be our roadmap to ensuring excellent compliant laboratory health care. And you'll see here our index of the final document. It's a 38-page document that each member contributed a section. It is written with the understanding that this document would be our marching orders on how we, laboratorians within CHI, approach laboratory compliance, and using the OIG model compliance plan as a template. It was basically a how-to. So it contains things like written policies, procedures, and how to meet the 7 elements of a model compliance plan, which I'm sure you're all familiar with. It talks about monitoring expectations, communication, and on the next page, it also contains guidance for common compliance issues or hot buttons, things like reporting laboratory results, billing and coding. Is a signature required on a laboratory requisition? We specifically have a section on proficiency testing, since that was a real hot button item, and how those specimens were to be handled. You know, it gives our laboratory leaders and our laboratory staff a resource of pertinent compliance information with an easy reference. Again, it's a how-to. Having a compliance plan is not required by the OIG, but having one helps demonstrate that an effective plan is in place. And it's certainly considered a positive should the OIG conduct an investigation. Again, the goal of our plan was to help us remain compliant and stay on the right side of the regulations. As a little bit of a side note, this is so important that every new laboratory leader within CHI, I personally meet one-on-one with them and review this plan and make certain that there's a complete understanding of what's contained in it. In the orientation, I always stress that they need to be familiar with what's here. They need to also be able to teach and explain to staff any new changes that exist in the plan. We stress communication, and we always talk about the communication has to occur between the bench which is in laboratory lingo where we perform tests, from the bench to the board. So in our instance, our information is transmitted from the technician, technologist, to the local CRO, and when appropriate, that person presents that to the board for communication. Reverse communication is just as important. We all talk about how to report compliance concern. Again, feedback is important. The best way to keep staff informed and engaged, this is the best way to keep staff informed and engaged, so they feel like their opinions or concerns are heard and count. You know, I know that the OIG prefers individualized plans, but we felt that using the strength of the system to alleviate each lab reinventing the wheel certainly was desirable. However, there is some room for local customization, focusing on entity-specific issues and or reflect local practices, but they may not supersede our national standards that are described in this addendum. To make certain this document is always current, our laboratories are always on top of changes and new regulations. Our committee reviews this document continually and updates it annually. Another great feature is this document is easily available online to all laboratorians through Inside CHI. And actually it's available to everyone through Inside CHI. Okay, so let's move on to the next slide. As we have discussed, we have a roadmap. So how do lab compliance leadership ensure education and understanding by everyone who needs to have it? This is a pivotal point expected by the OIG. And as a committee, we understood the importance of education and developed multiple strategies and a framework to accomplish this task. Our CHI roadmap requires every laboratory staff member to review an electronic education of this material and demonstrate understanding, and that must occur within 30 days of hire and annually thereafter. As I mentioned before, proficiency testing is a high-risk area for us. And so for our more complex laboratory, as you remember, this is what caused our physician office settlement described earlier. That settlement necessitated a second educational electronic teaching course to be developed that emphasized specifically proficiency testing. It's a very detailed educational tool, and we continue to include it in the CHI required education. The education doesn't just stop with our laboratory professionals who are stationed in the physical laboratory at a hospital. As laboratory testing moved out of the walls of the traditional hospital lab, it has now had to apply to anyone performing moderately complex testing or that higher level testing in a hospital or any medical environment. For example, nursing clinics, cardiology, ICUs, are now performing, in some cases, more complex testing that requires the same familiarity and applicability of the appropriate regulations. To accommodate those individuals who are not scientific laboratorians or in the lab, we developed an abbreviated nursing and clinic module. This education is not as detailed and specific as the laboratory proper education, but it contains the information that these individuals need to safely and compliantly perform their patient testing to reduce risk and to meet regulatory requirements. Let's move to the next slide. Okay, now this is a busy slide of it, so please don't, there's no needing to read it. I just want to describe to you how we keep track of all these compliance responsibilities. How do the laboratory leaders keep track of these things that they are required to do day in, day out, and year after year? We as a compliance committee develop multiple tools to assist our laboratory leaders in implementing and maintaining an effective compliance program. There's a lot of information in this compliance plan addendum. Everyone is busy. So we developed this strategy to assist leaders in order to keep current with laboratory compliance procedures. We reinforce compliance expectations by providing checklists like this one seen here to ensure that all required aspects of the plan are reviewed by the leadership and the staff to make sure that they understand any of their specific responsibilities as delineated in our plan. This year we added another aspect of compliance, another tool that ensures compliance to our HIPAA privacy requirements. This tool, this privacy checklist, was developed by our CHI privacy officer, and it reviews important privacy aspects, such as there is a process for validating the identity and authority of the patient whose staff are releasing and sending results. We have to have a process for it. We make sure that staff are aware and understand it. Once completed, both of these tools are reviewed with local compliance or their respective privacy officer. These processes serve to enhance better relationships with both providers and are a ready-made agenda which can be used to stimulate open and transparent discussions between the laboratory leader and these two important departments, compliance and privacy, making future conversations more easily initiated. So let's move on. So we have provided a roadmap. We've educated and provided tools to assist remembering the key tenets of our compliance and privacy plans. Now we needed to develop avenues to monitor compliance with these expectations. Answering the question, are expectations of the National Compliance Plan, federal and accrediting regulations being followed? We accomplished monitoring for that by taking the following approaches. Everything compliance is initiated by taking our monitoring cues from the government or other accrediting bodies, such as the Office of the Inspector General, the OIG, and the Joint Commission. These bodies publish their concerns or regulatory changes for review. And this year, we reconfigured our monitoring plan using these types of regulatory sources. There were two specific troublesome areas that were identified. Two tests, which were high volume, common test, a complete blood count, and a urine analysis. We looked at the usage of these two codes across the system and investigated any hospitals whose statistics did not conform with the average expected usage. We took a deep dive looking at systematic errors. Those are the ones that cause us trouble, where they're repetitive and occur over and over and over again. And these are caused by accidental coding issues, training issues, wrong test order due to error in training instructions. Corrective actions of any issues identified, and including operational changes and repayment, are made when it's appropriate. In addition, our monitoring was expanded beyond these two tests when we reviewed false claim cases reported in the previous year. It was that review that necessitated us to focus our attention looking at two drug screen codes during a specific time frame. We wanted to test at the entity level to make certain our CHI laboratories were coding these tests correctly. I will speak more to these results in a later slide. Our committee also reviews technical and quality assessments and regulations. Annually, when regulators publish the most cited violations of quality and technical regulations, for example, competency assessment, we review those and add that into our monitoring plan or my reviews for that year. So in this case, for competency assessment, it was one of the most frequently cited deficiencies, and where the findings demonstrated that laboratory staff technical competencies were being evaluated, but the educational qualifications of the staff performing those competencies did not meet the regulatory standards. So we're seeing that and educating that throughout our system. We monitored these focus areas to help us update our compliance plan, like I said, and where necessary, it continually serves as a resource and assists in developing corrective action plans when non-compliance issues are discovered. So, on the next slide, moving along, another approach to monitoring is my conducting and performing on-site technical and coding reviews for our hospitals and high complex laboratories. Selection of those on-site candidates are made in conjunction with the recommendations of local compliance and local entity leadership. Each on-site review is not only a compliance review, but it serves as a non-threatening educational exercise for laboratory leadership and local corporate responsibility. Answering questions firsthand and discussing any observations that needed to be tweaked because of regulatory compliance issues is in an open format has been found to be most productive. To add to the value of these on-site reviews, I also invite a local member of the National Compliance Committee to attend and participate in these reviews, as that experience helps them gain information and confidence that helps them serve as a local resource on a regional basis. As far as the very simple testing, that wave testing we talked about earlier, I don't conduct those on-site reviews, but a compliance representative does. Each year, our compliance group sets a percent of review expectation for all of those, remember, 400-plus laboratories. How many of them are we going to look at and review for compliance? And then they're reviewed by a compliance person or a laboratory specialist, and they perform the on-site reviews. For the simple testing reviews, a tool or testing checklist was developed for the layman so that CRP personnel could use it to evaluate the performance of those simple tests performed in our physician office labs called POLs. This process ensures that POL staff has definitely a contact with CRP, corporate responsibility, and they can ask them questions, or those questions can be referred to me or our national committee. And the review ensures and documents that these simple laboratories are meeting regulatory requirements, for which, in this case, there's only one. They need to follow the manufacturer's recommendation. All right, so moving along. So we need to talk a little bit about mitigation of the potential violations. How do we do that? What do we do? So things that we do to help mitigate these issues is we communicate with the laboratory leadership through regulatory updates, questionnaires, one-on-one contacts, the interpretation of any problematic regulation that we see or find. We directly report that to our laboratory leadership and to our corporate responsibility officers. We answer questions identified that may come to me, and we work with the individual laboratories to advise local leadership on resolution. And then we do that in conjunction with the local corporate responsibility officer. When we do discover discrepancies, we request a plan of correction be developed by the local laboratory leader, and that is approved by local entity leaders, reviewed and monitored by the laboratory compliance team. Okay, so let's go to another busy slide. Again, it's got a lot of information on it. Please don't worry about reading it, but I want to just talk about the concept and what that includes. We already talked about the monitoring activities and what happens if a technical error is identified. So what happens if something is billed or coded incorrectly? If a billing or coding error is discovered, the evaluation and analysis process can become very complicated, considering a 6-year repayment window requirement for Medicare. The complication is primarily due to regulations changing frequently, which often occurs. So calculations and data needs requirements have to change and alter to conform with any regulatory updates and changes. In addition, sometimes it's very difficult to get data from our legacy or systems that are now out of operation. So worrying and going back 6 years does sometimes present quite an interesting dilemma. As an example, this form that you see has been designed to help organize and provide any laboratory leader and CRO to help them guide them through the steps to follow if some billing error is discovered. They're provided with a notification cascade, who to include on notification, legal, CRO, entity leadership, myself. All those things are laid out for them because they don't encounter this often. So typically, laboratories have many areas in billing where things can go wrong. Some of our hospitals, for your information, have over 3,000 lines of billing codes. That's a lot of codes that have to be maintained. And errors occur because retrospective reviews are hard to accomplish. Change in laboratory leadership, different coding practices and interpretations may cause for an incorrect code to be applied. Codes outdate, codes change but are not maintained. So these are the things that we see typically that occur. In addition to notification, this document gives the lab leadership activities to conduct simultaneously as to what information needs to be gathered and for a complete analysis. For example, the identity and start and collection date of any particular issue has to be determined and documented. Who's responsible? Who follow-ups with coordinating an investigation? Quantitation, notification of payers, and repayment if necessary. Okay, let's move to the next slide. So through our monitoring efforts that we just talked about, and over the past 2 years, we've discovered the following when we identified issues that required repayments. In 2017, we conducted 11 projects with the assistance of our Crowe auditor partners, which resulted in $582,000 in repayments and the development of future avoidance corrective actions. These error findings were primarily due to various individuals' misunderstanding of billing guidance. For example, choosing the wrong code that did not reflect the test we were actually performing. In 2018, if you notice, we looked at, and we talked about this a little bit, we looked at specific OIG identified troublesome spots and reviewed entity data. Any entity whose data showed potential misapplication of a billing code or any of the regulations were selected for a deeper review. Through that analysis, we identified 68 labs that needed to be investigated further, 17 out of which, or 25%, had been selected, we had discovered, had one or more finding that required follow-up. And that sort of follow-up is continuing today as we speak. Okay, so on the next slide, we'll talk a little bit about some other common errors that I find frequently. One's worth notice or mentioning, and I'd like to discuss some of these errors with you. For example, reflex testing. Very interesting. CHI and CMS's definition is it's the ultimate intent of the physician's single order if it requires additional multiple tests to results to meet that intent, then it is appropriate to bill for multiple tests that give the physician the result of the initial order. If that is not the case, an additional test may not be added just without the consent of the treating physician. When utilizing a reflex testing protocol, which is approved, and it's not a problem, the provider orders a test, and that order itself specifies that additional tests will automatically be ordered and given depending on the initial results, which meet predetermined criteria. Then the initial and additional tests are individually billable. Laboratory leadership is responsible for making certain that the ordering provider understands at the time of the order what their actual order is going to accomplish and what test result has, depending on the actual test result of that order. The entire process causes much confusion and is explained thoroughly in our laboratory compliance addendum. A common misconception which often occurs is that the medical executive committee can unilaterally decide for all physicians that additional tests can automatically be ordered given a certain circumstances, as decided by the MEC. But that is not the case, and only the ordering provider can make those decisions as to what is needed to treat their patient. Moving on to incomplete panels, another one we find that pops up is where there are approved panels, which may be a series of chemistry tests or chemical tests, and one of them, one of those tests, for whatever reason, is unsuccessfully analyzed. A common misconception is that billing the panel is less expensive than billing the components, which is not true. We also see environmental monitoring not being followed, as well as personal policies, and I've described competency assessment before. So moving along to the next slide. How do we avoid some of these problems? Well, we make sure that the requisition is clear and make certain that the ordering physician understands it. We also ask that the laboratory provide general notices to the physician, which gives them an understanding of how to use the laboratory, and under what circumstances tests will be ordered, and perhaps that's where we include reflex testing. Custom panels, profiles, we do not encourage those. That is typically known as a Dr. XYZ panel, where multiple tests are ordered on the say-so of one physician. Those have specific regulatory requirements, and we definitely discourage them at CHI. So the last thing we do is we educate the providers to an item called an advanced beneficiary notice. And if we explain to them that if they do not provide medical necessity for the testing, the patient will be asked to sign this at ABN, the advanced beneficiary notice, stating that they are financially responsible for these tests, and that would cause perhaps a delay in treatment or a misdiagnosis. Okay, moving along. Outside of working with CH Laboratories, I also work with CHI Advocacy. So I bring our CHI Laboratory concerns to our legislators that may help in shaping regulations, making requirements more relevant. For example, and we'll go through some of these more in detail later, I've worked with making comments on PAMA, which is Protecting Access to Medicare Act, laboratory workforce stabilization. There's a drastic shortage in laboratory staff, particularly throughout our critical access hospitals. CLIA, the Clinical Laboratory Improvement Amendment, we've made many comments on that, where that is the main regulation that governs laboratory compliance. Glucose monitoring, worked with the FDA, and looked at critically ill patients and how and who can do that glucose monitoring. Okay, on the next slide. On some occasions, we actually write comments to the agency who's developing the regulation or has direct oversight. Again, as I spoke before, we did this with PAMA, the Protecting Access to Medicare. We did it with CLIA. You see there it says RFI, Request for Information. The regulations hadn't been updated since 1988, and CLIA requested our laboratories to comment on what would make them more relevant to today's technology. So we at CHI provided response to that. We also worked with the Food and Drug Administration on new technology. One of our hospitals wanted to implement the OptiScan 5000. It's a new technology that has a direct monitoring of critically ill patients' glucoses in a non-laboratory, non-traditional way. So we are working with the FDA and assisting regulators in developing appropriate regulations to implement technology in a safe and effective manner. Moving on. Okay, so Susan had mentioned that I and my committee also works with many professional agencies, and here is a listing of those who I work with on many advisory committees, and on each of these I'm advising them on how to implement regulations and their rules on governing laboratories. So to be part of these agencies does actually increase CHI's clout because we can respond to questions at CHI, but also we can make our issues and concerns be known to these agencies. So that tends to give us a little more clout from a regulatory perspective. Okay. Moving on to 23, the next slide. So I just want to touch on just a couple significant developments that affect our payment for our hospital outpatient tests. This slide, I won't go into a lot of detail, but CMS has developed a hospital outpatient prospective payment system where they're packaging laboratory tests with other outpatient procedures that are performed on the same day of service. They no longer pay us an individual amount for the laboratory. And that is only unless they'll pay us separately for non-patient tests and for hospital out services that are from a different encounter and unrelated. So non-patient tests are basically specimens that are drawn by other individuals outside of the laboratory that are not employed by the hospital. So they'll still pay us if we receive testing samples from outside the hospital, and if the patient comes in and is a hospital patient and only has laboratory testing performed, they'll pay us additionally for that. Otherwise, everything's bundled into a basically outpatient DRG. Okay, next I want to just go over a little bit about something I've talked about in a few slides, which is PAMA. This is a significant development that will affect the way CHI is reimbursed in outpatient setting. Again, it's PAMA, Protecting Access to Medicare Act in 2014, and the goal was to set a new reimbursement rate to match the weighted median of a reported commercial rate paid to large commercial laboratories. CMS estimates that laboratory Medicare revenues to us will increase $5.2 billion over the next 10 years. This PAMA regulation, which is still an area of conflict to all laboratories, went into effect January 1, 2018, and will be phased in over the next 5 to 6 years. It is due to regulations like these that we have that may have a dramatic effect on our ability to care for our diverse patient needs, that CHI needs to be at the table and to be part of a solution affecting regulation prior to and after implementation. So on the next slide, so what is your fiduciary responsibility? What do you as a board member need to do? Well, here they are. Ask questions. You need to understand the risks as related to laboratory compliance, which hopefully I've explained some of them to you today, and that you need to confirm adequate internal controls are in place to mitigate risk. I've talked a little bit about those today. And last and most importantly, we have to ensure patient safety. So let's move to the last slide. So to start that responsibility, I want to thank you and ask us for any questions.
Ladies and gentlemen, if you have a question, please press star followed by 1, and you'll hear a tone indicating you've been placed in queue. Once again, for any questions, press star, then 1.
Hi, Rich. This is Susan. While we're waiting for questions, I did have a couple questions for Tim. So, Tim, what do you see as the biggest challenge to ensuring compliance with the federal and state laws that regulate clinical laboratories?
Thanks, Susan. Great question. You know, it's the sheer volume of laws and regulations that are being applied to laboratories that make it difficult for any organization to keep current. You know, it's hard because sometimes there's a difference between a state and a federal law, and there's a difference between state, federal, and an accrediting, a Joint Commission or other accrediting agency's law. It makes it very hard for me and our laboratories to comply with any or all three of them. But CMS is being more intentional about it, and part of that, and they're expecting those that are conducting inspections in lieu of them are enforcing the law the way that they're interpreting it. So they're trying to make them all enforced uniformly. So that's a good thing, and it's probably the most difficult for our labs to comply with.
But certainly we can see the benefit of having a consistent, overarching laboratory compliance plan, like you explained, at CHI.
Yep, and our committee stays right on top of any new development. And being part of these professional societies helps us know when things are being proposed and are in the pipeline.
Mm-hmm. So have you seen a difference in enforcement activity over the last couple years?
You know, I have. I think that is partially a reason when we talked about the RFI, the request for information from CMS, that's part of the reason that came about, because they're trying to be very strict on their enforcement, but because of the ambiguities and the outdatedness of their regulation, they're running into the problem of making those enforcements stick, so to speak. And also I see the proficiency testing regulations as being very strictly enforced, and has been, it was strictly enforced by CMS, and now with their bigger emphasis for uniform across the board enforcement, the accrediting agencies are getting more and more stringent and citing laboratories, and that causes significant issues for the laboratory to resolve.
Great. Thank you.
Sure.
And once again, as a reminder to the phone lines, if you have a question, please press star followed by 1. And speakers at this point, no one is queued up.
Okay. One of the things I did want to mention that Tim said as to the board's fiduciary responsibility, around asking questions, understanding the risk, and some of the information that you should be receiving from your local CRO is related to like our monitoring scorecard. And included in that is the laboratory monitoring that goes on throughout the year by Tim and his team. So those results are included on the scorecard. So, if you had any questions about what those results mean, please make sure that you follow up with your CRO. Okay. Rich, any other questions that came through?
No one is queued up on the phone lines.
Okay. Well, Tim, thank you so much. We certainly see the benefit of the program that was put together. Unfortunately, it takes an issue that comes up and, why we had to do it. But I think DHI has certainly benefited from it. And, the work that you and your team do have greatly enhanced, not only just being compliant with the rules and regulations, but certainly also improving quality of patient care.
Well,
Thank you so much.
Sure.
Okay, I think, thank you all for joining us today.
And ladies and gentlemen, that does conclude your conference for today. Thank you for your participation, and thank you for using the AT&T Executive Teleconference Service. You may now disconnect.